I'm excited to introduce Dr. Behnam Saberi from the Division of Liver Disease, who's going to give us a talk on updates in hepatocellular. Welcome.
All right, thank you. Thank you for having me today. So I'm gonna, try to review the topic from gastroenterology and hepatology standpoint, and just probably touch base on some of the topics that I thought are more relevant for us. So hepatocellular carcinoma, as you know, is the main type of primary liver cancer. Based on recent epidemiologic studies, it's reported that globally there were about 854,000 incidence cases, and they were, as you can see, there are many deaths related to this cancer. In the U.S., you can see that it's reported that it's on the rise. If you look at the distribution of etiologies of liver disease in patients with liver cancer, of course, in the U.S., the most common etiology is hepatitis C. As you can see, this is a national transplant database in the U.S. 50% of the cases were related to Hep C, and then this is usually followed by alcoholic liver disease, 8%, fatty liver disease, and chronic hepatitis B, and then the rest of the etiologies that are less common. Majority of patients with hepatocellular carcinoma, as you know, they have cirrhosis of the liver. In most of the etiologies, you will see about 80–90% of the cases are cirrhotics. In NAFLD, there are some recent data that suggests maybe there are some patients that can get HCC without having cirrhosis of the liver. Usually, as you know, when we see patients at risk, we enroll them in surveillance programs, and what that entails is that we enroll them with ultrasound and AFP every 6 months. The question is there benefit when we enroll patients in surveillance programs? And the answer is this was a study that was performed in China, 2 arms. They had 9,000 patients in each arm, and they basically showed that the patients who go to the surveillance arm, they have better survival compared to the other group, and that's probably related to the fact that we detect these patients earlier and we have resections and other curative treatments for them. Again, the issue with surveillance currently is that the AFP and ultrasound even combined, the sensitivity is about 50–60%, so it's not a great test. And I just want to touch base a little bit about alpha-fetoprotein. As you know, it's a fetal glycoprotein. In the early life, it's basically as in embryonal life, it's mainly secreted from the yolk sac, and as you can see after birth, it drops to the normal levels. If in adulthood, if you have some situations such as inflammation or liver, regeneration, it can slightly go up. And in patients with liver cancer, we have the number of AFP that in certain patients with HCC can increase. Now the issue is that one is that the cutoff is a little bit hazy between studies, and also the other important point is even if you set the cutoff as 20, only about 30% of the cases will secrete AFP. Now, the genomics of the HCC recently has been extensively studied, and I just want to explain to you why I think AFP in some tumors are high. And the reason for that is they described a group of tumors that are more aggressive and are originating from progenitor cells, and these are the tumors that secrete AFP, and these are the tumors usually associated with worse outcomes compared to the tumors that come from non-proliferative type of HCCs. So the bottom line is you have 2 groups of tumors that are one that are probably originating from more matured hepatocytes, and these are the tumors that do not secrete AFP. And if you have tumors that are more kind of similar to the, kind of probably yolk sac type tumors, those are the tumors that secrete AFP. There is probably a terminology you heard, AFP-L3, which is basically an isoform of AFP and has this more related to fucosylation on the molecule, and the type 3. L3 is what is more related to the HCC tumors. The question is where do we use that? And this study looked at these AFP-L3 patients in and they basically concluded that the patients that have AFPs between 20 to 200, if you use a cutoff of 35%, the specificity for detection of HCC increases to 100%. So just to summarize this part, we usually do AFP and imaging. Of course, the best way to diagnose HCCs are through MRI and CT liver protocols. For the patients who have low AFP tumors, we probably need better biomarkers. In patients who have borderline AFP levels, maybe AFPL3 is something that we can use in the clinic. And of course, the patients who have very high AFP levels, these are in this group of patients, probably AFP is more useful for us to use. The problem is these are minority of the patients. They're not only a group of patients that we can use. Just to give you some idea about some of the newer biomarkers that we are starting at Sinai, as well as these are multi-center studies. We are looking at these focusylation. These are basically some focus moieties on the glycoprotein molecules on the HCC. We are able to detect these in the blood of patients. So this is one of the biomarker trials that we're having. There's another biomarker that probably going to start soon as well. It's methylation on the DNA molecules. They're trying to understand the patterns of methylations on the cells in HCC. And also, there has been a study that has been going on for quite some time now by Augusto Villanueva, and they're looking at circulating DNA, RNA test. Very similar technology that they're detecting colon cancer in the stool. They're trying to, use that in patients with HCC in the blood and serum. Now, the other promising area in surveillance is that this is being investigated by Dr. Tully from radiology at Sinai. This is called abbreviated MRIs, which actually are shorter versions of MRIs. They're cheaper, and they last about 15 minutes, and they actually have a very high sensitivity and specificity in surveying patients with HCC. Now, of course, the question is, who are patients at risk? And the answer is the patients who obviously have cirrhosis are the highest risk group of patients developing HCC, and patients with advanced stage fibrosis. If you look at these patients, the risk of HCC development is about roughly 3% per year, and it really depends on the etiologies of HCC. For example, in autoimmune patients, the risk is a little bit less. I'm going to mostly focus on fatty liver and HCC because these are some of the more important topics these days. As you know, there is a growing epidemics of obesity and related fatty liver disease in the U.S. More than 25% in this report from WHO. Patients with NAFLD, the ones that develop inflammation in the liver, can progress to scar tissue and cirrhosis, and that's about 10 to 20% of the patients throughout the course. And when they develop cirrhosis, of course, these patients are at risk at HCC. Now, hepatitis C, a natural history is, of course, when you get the virus in the liver acutely, about 70–80% of these patients become chronic. And out of those, about 20% over 20 years will develop to go toward cirrhosis of the liver. And that is the main risk factors for development of HCC. As I said, is about 3% per year risk of HCC development. And again, hepatitis C is the most common etiology. That's why I want to spend a little bit of time on the Hep C topic. The virus was discovered in 1989, and they developed the assays. And as you know, there were earlier treatments with PEG interferon. And then we have the breakthrough discoveries of these direct-acting antivirals. And there were a few waves of few generations that came. But I think the most important time point was around 2014 when we developed medications such as sofosbuvir. And then we had medications such as Harvoni, and basically these were the time that they called it interferon-free drugs with the DAA. So we're not using interferon anymore with the regimens, as you know, and we are using just the pills for treatment of Hep C. Now, if you look at the course history of treatment, of course, the interferon era, the medicines were associated with significant amount of side effects, and now, as you know, we are able to cure more than 90% of the patients with the direct-acting antiviral medications, achieve SVR in these patients. Now, the hepatitis C and HCC are kind of associated in just multiple ways. I try to make a few relevant clinical points. One is that when they enrolled patients with hepatitis C in the clinical trials, they excluded patients with hepatocellular carcinoma. So we really didn't know what's the SVR rate in a patient with Hep C and hepatocellular carcinoma at the same time. Now, some of the retrospective studies that were recently published actually showed that the rate of SVR or cure rates are actually lower than patients without having hepatocellular carcinoma, about 60 to 70%. Now, this is an example case that we treated here. This was a patient with a massive hepatocellular carcinoma in the right lobe. You can see a very hypervascular tumor, and patient was treated with Epclusa, one of the stronger medications that we have, and basically patient failed the treatment. And the question is why is that? And there have been some different proposals on the mechanism. It's not exactly clear, but one idea is that when you have a tumor, the virus can basically hide inside the tumors, and when you give the medications, the drugs cannot target the virus. And when you're done with the medication, the virus will relapse. And the second idea is that the drugs usually enter through portal vein, but the HCCs are being fed mostly by arteries, so that's why probably the drug cannot reach the tumor. So this is interesting, some of the ideas about why some of these patients might fail the medications. The other topic related to hepatitis C and HCC that was recently being published, I don't know if you saw, there were a bunch of papers and hepatology papers, was related to some groups suggested that if you treat somebody with Hep C with direct-acting antiviral, then they are at risk for getting actually HCC and getting recurrence or occurrence of HCC. And but this has been a matter of controversy. As you can see, multiple papers were published, 2016 and after. This group basically did a meta-analysis and looked at all of these papers together, and they actually did not see any association that treating somebody with the new generation drugs will create HCC. So it hasn't really been confirmed, although I have to say these studies are, a lot of them are small, heterogeneous studies, but the meta-analysis didn't reach a conclusion with that association. Some of the biggest studies related to hepatitis C topic and HCC come from a VA group, Dr. El Siraj. And as you can see here, they studied thousands of patients. They looked at the same topic, looking at patients who were treated with the new drugs and achieved cure versus the groups that did not achieve cure. And you can see the risk of HCC development in people who did not achieve the cure was increased. They also showed that if you cure a patient with hepatitis C and follow them afterwards, usually the patients who develop HCC who are at risk are the people who have cirrhosis versus no cirrhosis. The patients with no cirrhosis actually were at risk of below 1% per year of development of hepatocellular carcinoma. This was a study we looked at with Dr. Myron Schwartz at our patients at Sinai, and we were basically focused on patients with hepatitis C and hepatocellular carcinoma who were undergoing liver resection. We looked at the resection samples, and we were interested to know in patients who were cured with the hepatitis C drugs, what was the basically stage of fibrosis on the resection sample. And what we found out is that interestingly, about 40 or 50% of the patients did not actually have cirrhosis on the resection. So again, this brings the point that patients who are treated with new generation drugs for hepatitis C, even if they don't have cirrhosis, they're still at risk, but the risk probably is not as high as somebody with cirrhosis. Now, in real world, when these patients who are cured of Hep C come into our clinics, the question is, what do we do with these patients, and how do we assess the fibrosis score? Because we don't have resection on everybody. We don't have liver biopsy these days on everyone. And I just wanted to show you that there are different ways that you can evaluate liver fibrosis, because this is the most relevant thing that has association with development of hepatocellular carcinoma. That's why it's so important for us to determine that. Now, you can see there are multiple ways that we can determine liver fibrosis score. The problem with these is they're probably accurate about 60% or a little bit more than that. So they're not really perfect ways for us to assess the fibrosis. Now, there is a newer technology that we're having in the liver clinics. It's called a FibroScan or liver elastography. And this is the machine, as you can see. It's basically a shear wave technology that sends waves throughout the liver, and depending on how fast these waves travel, you can actually tell how much scar tissue is in the liver. And just give you a rough idea, you start at stage 0, stage 4. Based on the previous studies, we know exactly what score means what. And, this basically tells you if they're stage 1, 2, 3, up to 4, which is stage of cirrhosis. Now, I give you an example. This is one of the actual 2 cases that were reviewed. You get the readings on the right side here, and then you basically calculate IQR, and you get 2 scores. One is CAP score, which is basically the measurement of the fat score, and the right number is the measurement of the scar tissue. And the bottom line is if above 12, this considered a patient has cirrhosis of the liver. And this case, for example, was 3.2, which is normal. And then in this case on the right side, 27 is very high. So this patient with the FibroScan has cirrhosis. And again, this method is more accurate than some of the blood biomarkers. I would say probably roughly about 90% accurate on detecting cirrhosis of the liver. Based on some recent studies, they showed that if you treat patients with hepatitis C with the newer drugs, the score on the FibroScan might drop immediately after treatment. So that's one of the things that we need to put into consideration when interpreting the study results. Now, just to give you a rough idea, this is probably what's going to happen in the future. And this was studied by a group from MGH, and they basically did some mathematical modeling, and they're looking at, okay, what's going to happen in 2030 or after. And this is in the past, right? So we had a lot of patients. This is SVR, viremic, and there are some people who are not aware of their diagnosis. So in the past, most of the cases we were seeing in the clinics were people who had active hepatitis C. So now we have these drugs, and we're able to cure more than 90% of the cases. So probably when we are practicing in the future in hepatology clinics, we're going to see a lot of patients that are already cured of Hep C, but we still have to tell them what to do and how to monitor them, and they're probably minority are the people who actually have the virus. The HCC risk or development probably will take quite some time to drop. So we're still going to see a lot of the HCCs coming to us in the clinic, and you can see here in the DAA era, this column, the rate is dropping down the line, but we're still going to see a lot of HCC patients coming and being diagnosed by us. So we need to know exactly what to do with these patients. This was a study, just to give you an idea. We looked at liver transplant recipients, and in the US, there were about 27,000 patients, like half of them were Hep C, and we looked at the recent era with the new hepatitis C drugs, and we basically noticed that even now that we have the cure, we still Hep C, although it's a little bit of drop, we still see that majority of the cases with HCC or liver cancer are still hepatitis C. So again, just proving the concept that we're still going to see a lot of these patients coming to us. Currently, based on the ASLD guidelines, in cured patients, if they have stage 3 or 4 fibrosis, they recommend to continue surveillance. In less stage fibrosis like F0, F1, F2 is still less clear cut. Currently, the guidelines do not support to screen or survey these patients. So just to summarize this part, when somebody coming with hepatitis C cured, we see these patients in our clinics. We have the fibrosis stages before and after treatment. And we basically currently with the low stage fibrosis patients, the guidelines do not support to continue with the ultrasound and alpha-fetoprotein in these patients. But I think we probably need more data in the future to kind of understand this group a little bit better. In patients who have advanced stages of fibrosis and cirrhosis, the guidelines currently support to do the alpha-fetoprotein and ultrasound every 6 months. If there is a suspicion, then you do your liver imaging. And then if there is a problem, of course, you refer the patient to the right treatment for hepatocellular carcinoma. Yeah.
If we downstage those patients to like stage 0 to 2 after a few years, do they then go into the lower risk category? Or is that
so this is also not very clear, but I think usually the hepatologists are using the baseline FibroScan right now. But you're right, the FibroScan drops, but I don't think we have a really good study to kind of look at that. That's a good question. Okay, so the second part that I wanted to touch base is the treatment of hepatocellular carcinoma. It's more like just an overview of just giving you a rough idea of what we do with the patients with hepatocellular carcinoma. So it's mainly with the guidelines that we're using is from Barcelona group. And this is, when you look at it first, it looks very complicated, but I just want to make it a little bit more organized. So the upper part of the panel looks at a few things. One is the functional status of the patient, how, if they're walking or doing the regular activities. Of course, the size and number of the tumors, and also the stage of the grade of the portal hypertension. So based on those information, you can put the patients in different categories and then decide what exactly to do with each patient. And the second line is basically telling you based on the information you get, what stage they're at. And again, this is just a name of the stages: very early stage, intermediate, advanced, and terminal stage. And then you have your treatment options here. It ranges, really varies between locoregional therapy, resection, transplant, and of course the very advanced cases which are supportive care. This group here are the patients that really don't have very good survival rates. So most likely the best option for this group is just to do supportive care. Unfortunately, majority of them die within 3 months. Now, I wanted to briefly talk about a couple of these options. One is the liver resection. These are usually patients that have a single lesion below 2 centimeters. They don't have portal hypertension, functionally great. So these are, and again, resection doesn't get done in some of the centers. Of course, Sinai, Dr. Schwartz group, they have been doing a lot of resections for the patients. And I just wanted to give you a rough idea. The few things they look at is they look at the portal hypertension grade. If their platelet count, for example, is very low, those are probably not very good cases for liver resection. Or let's say their bilirubin is significantly high. The issue with resection is that it works, but then the patients can get recurrence because you still have the rest of the liver there, and the liver is cirrhotic or fibrotic. So that's why they get recurrence. And the recurrence rate is reported about 70% up to 5 years. So I think that's the issue with the liver resection. And again, part of it is because you have your deceased liver still there. There are some predictors of tumor recurrence that have been described. If somebody gets liver recurrence after liver resection, sometimes they do locoregional therapy, again, depending on the case, resection, or they can move forward with liver transplant evaluation. The second option...
is that because the screening options miss multiple HCCs that are already there.
Uh,
Going after the big one, but there's a bunch of little ones that you miss.
That is one possibility. Of course, they're not 100%, but I have to say MRIs are pretty accurate. But again, when you get recurrence, you're able to say if the recurrence is in the same place or in a different place. You also are able to say how fast the recurrence occurred. If it was around the same area, like 2 months later, that's probably the case, that was around the same area. But sometimes what happens, the recurrence, like let's say happens 2 years later in a different spot in the liver, and that probably is a different tumor. The liver transplant, I briefly tell you the history of liver transplant. This was started around 1987, and they gotten better over the years, as you know. With the HCCs, originally they were doing HCCs, but the problem was the patients were dying, and part of the reason was they were including a lot of sick patients, very advanced stage cases. And then they realized that when they do incidental HCCs, they found incidental HCCs on the explant, those patients actually do really well. So they, over the course, they learned exactly how to select patients to improve the outcomes for these patients for transplant. The most common criteria used, as you know, is called Milan criteria. Either one lesion below 5 centimeters or 2 or 3 lesions below 3 centimeters. They noticed that if you transplant these patients, the rate of tumor recurrence after transplant is actually pretty reasonable, and the survival rates are pretty reasonable, up to 70% at 5 years. So this is currently one of the criteria that are being used for patient selection for transplant. I think the issue is that still not that accurate in predicting of post-transplant recurrence with the area under the curve of, I put multiple criteria here, but it's not great. It's about 0.65, 0.7. So definitely we need better biomarkers, and it just tells you that it's not just the size and the number of tumors, probably more complicated than that. Tumor biology and other things are relevant here as well. There are some things that are important on the explant to pay attention to. This is, for example, microvascular invasion, the tumor inside a blood vessel that increases the risk of post-liver transplant recurrence. In the explant, you see these embolization material that were used before transplant, so it's kind of common to see some of these from TACE, for example, inside the explant. And it's interesting. Now, the problem with the post-transplant recurrence, when the patients recur, the survival rate is extremely low. Unfortunately, a lot of these patients die. One of the challenges is that 2/3 of the tumor recurrences after transplant are could be extrahepatic. So when it's extrahepatic, you're dealing basically with Mets, and those are very hard patients, of course, and we don't really have good treatment options for these cases. And the other idea is when they're on immunosuppression, there are some thoughts that the immunosuppression will make the tumor sometimes grow faster or become more aggressive. So there are some ideas about that. I just don't want to go through this too much in detail, but I just wanted to introduce the idea of hepatitis C treatment. It becomes a little bit challenging. Sometimes there's a debate, should we treat the hepatitis C before transplant or after transplant? I would say most of the transplant centers, they treat the hep C currently after transplant, is because they saves patients time on the waiting list, so they may get transplanted earlier if they use a hepatitis C positive organ to a hepatitis C positive patient. The last part of the talk that I wanted to touch base about some of the chemotherapy regimens in patients with advanced stage liver cancer, which are patients who have also portal vein invasion. Yeah. Doesn't matter because the medicines are so strong. They are pangenotypic now. We have Epclusa that treats everything, so no, it's a good point. But to your point, and I wrote it here too,
if you get a genotype 3, it's a little bit more difficult to cure that patient compared to somebody who have genotype 2. So there is some disadvantage. The other disadvantage is there is a category of disease called fibrosing cholestatic Hep C. So sometimes the patients might quickly go to liver failure from Hep C. It's kind of like a more acute. It's just not very common though, not very common. So this group have invasion to the portal vein. The survival, you can see, not great. The main medication that was actually, the study was done here by Dr. Lovett, SHARP trial, used sorafenib. They had a few hundred patients in each arm. I just wanted to show you roughly who are these patients who get enrolled in the clinical trials. And as you can see, a majority of are the ones that have portal vein invasion, as mentioned here. And some of them have metastatic disease or extrahepatic disease, and majority of child A patients. And they had some prior treatments, but no chemotherapy. So in this trial, basically, they showed that sorafenib was superior to placebo, but as you can see, the survival even with that was really poor, right? 10.7 months versus 7.9. Again, just points that these are very, very sick patients. The risk of dying from their liver cancer extremely high. The problem with sorafenib are the side effects. This is one of the typical presentations of somebody who gets sorafenib. They get this syndrome, and so again, 20% or more of the patients are not able to tolerate sorafenib, so they have to stop their medications. Recently, there are a few different trials that are ongoing. They're looking for other tyrosine kinase inhibitors. This was one of the medications, lenvatinib, basically hit the non-inferiority on the trial. But again, you can see the survival is very low. And this medication recently was approved for treatment of hepatocellular carcinoma as well. The other medication that's very interesting, and I'm sure you see some of these medications in gastroenterology too, is these PD-1 and immunotherapy medications. And basically, what they do is they remove the brake on the T cells, and you have more active T cells, cytotoxic T cells that get activated. And the idea is those cells then they can attack the tumor cells and kill the tumor cells. This was recently studied in a clinical phase 1 trial, and they're doing more trials down the line. But basically was used in patients with advanced stage HCC. What they saw is that the response rate is about only basically works in 20% of the patients. It doesn't work on everybody. And the other challenge is like you don't know who's going to have a response. And the survival was only about 15 months. But I have to say, some of the cases could have actually complete response, which is really impressive. Some patients, when you treat them, we go to the conferences, they actually complete, the tumor is completely gone. So that is very, I think what is very interesting about these drugs, and they're trying to understand these drugs a little bit better. Now, as you know, there are side effects associated with immunotherapy drugs too, because when you activate the cytotoxic T cells and the immune cells, then they can start attacking all over the body, right? And this is what we see. For example, you probably see the cases that present similar to IBD. We also see cases in hepatology side that present with AST, ALT levels in 5% of the patients or less. But I have to say, I get some referrals on these cases. Some of the autoimmune-like hepatitis is very severe. We just had a case in a hospital that had AST, ALT in the thousands, and INR went to 4, and patient actually passed away from the side effect of these medications, the immunotherapy. And just to summarize this part, in the first line, currently we have sorafenib and lenvatinib. These are tyrosine kinase inhibitors. We talked about the survival. In the second line of treatment, we have other tyrosine kinase inhibitors that are currently approved. And of course, we have nivolumab. I think the future of HCC in this area would be probably combining, like for example, nivolumab with lenvatinib. There's currently a trial here that showed better actually results compared to nivolumab medication. So I'm going to summarize here the talk. So again, what I showed is that hepatitis C remains the main etiology of liver cancer in the US currently, even with having the cure for Hep C. So it's probably going to take a while for some of these Hep Cs to be cured. And then, of course, we have NASH still on the rise. That's one of the major majority of patients that we see in the clinics now. So current guidelines in the hepatitis C cured patient is that if they have advanced stage fibrosis, we do the surveillance for liver cancer. For treatment of liver cancer, we talked about liver resection, has a very high rate of recurrence. Liver transplant is a good treatment option for patients with early stage HCC within Milan. But again, organ allocation, organ availability is a major challenge. And then in the advanced stage group, we have immunotherapy with some promising results, and there are some ongoing trials with the combination of these drugs. Would be interesting to know what's going to happen. Again, thank you so much for your attention.
These patients are sometimes being discovered too late. That's a lot of time. So is hepatitis C screening part of a routine physical? I don't think it is.
No.
Right now.
Yeah.
So for is for baby.
You're supposed to screen every baby in primary care.
You just go through you guys. And but the younger people don't get it. I mean,
So the part of the guidelines, yes, is baby boomers, but we actually currently have an epidemic of IV drug users in the young population.
Yeah.
It's well known. A lot of them are getting. It's interesting. Somebody from emergency room was presenting some data to us, and they basically went to the emergency room and started screening everybody.
and
And they had very high rates of Hep C.
well, that's what I'm asking.
I mean, and it really depends on which area you're at, right? Probably some areas in the country have higher rates of Hep C, but so you're right, definitely.
Certain ethnics.
Yeah.
Egyptians are
Yeah, Egypt has highest because they used to treat schistosomiasis in Egypt, and they were sharing needles back then. They didn't know about Hep C, and a lot of people basically got Hep C.
That's a great summary.
Thank you very much.
Thank you.